password is the same, I just keep it the same because I'm absent-minded professor. So it's practice 1, 2, 3 with no lowercase, all lowercase, no spaces, practice 1, 2, 3. And then when I usually do a practice, I try to have the review right after so you can look at the answers. And the password for that is practice 1, 2, 3. Okay? But please don't obsessively, compulsively check Examplify looking. I will promise I'll send an email when it's up, and it probably will not be up until late tonight, like, you know. But it's usually like a 5 or 8 question, sample questions about pregnancy at risk, okay? It's just to make sure your device works, that when I send the exam out using ExamSoft, that everybody's in the right course, and all of our devices are working before Tuesday, okay? And then tomorrow, we'll talk about and see if you have any questions about that, but you could probably even do it in class if you don't get to it. But I'll have it so that you can do it in the morning before class if you wanted to. Or you could not do it, it's entirely optional to you, okay? So with pregnancy at risk, you may feel a little more comfort in this because it's kind of med-surgy, all right? It's like, oh, yes, I do remember these things. The bad thing is I don't have 2 semesters to go over all of these things. I have a lecture in 20 minutes to go over these things. So we are gonna hit them very superficially, and you have to think about them in context of pregnancy, all right? So yes, you know diabetes, but now we're gonna look at what is the issue with diabetes in pregnancy. And I think, for me, the book is sometimes it goes into a lot of detail, a lot of pathophysiology, and I think that helps you understand the concept better. I'm not gonna talk a lot about that. My emphasis is more on the nursing care of the client. I also posted some additional resources because I feel like they are phenomenal because it gives you the need to know and kind of a short amount of information. I know there's some discrepancy. So for example, the values for glucose tolerance test in the article don't match up exactly with the values that you see in the book, okay? I would never ask you something that's right in one place but wrong in the other. I'm not testing you over whether you read the article or, you know, which one is right, okay? And I think that's another thing I'll kind of cue you in as to what things are kind of need to know information. You'll notice in this section, I have numbers and I'll mention things, I'll mention certain medications, and there's a reason for that. So that should help kind of cue you in on what you need to know in this content, but it's very complex. Pregnancy at risk, we are talking about things during pregnancy, and some of these things we will revisit again when we do intrapartum at risk. So we'll talk about taking care of women during labor with preeclampsia and gestational diabetes. So this is all before labor delivery, okay? So if you'll notice, 1, 2, 3, 4, 5, 6, 7 items listed here, okay? You have the cause and prevention of hemolytic disease of the newborn secondary to RH incompatibility. You already know this. We've already talked about this. And then talking about the route of transmission, the effects of the fetus, and again, they're pretty simple. It causes miscarriage, fetal death, for torch infections, group B strep, and HIV. Obviously we only have about 20 minutes, so we're just gonna start this today, and then we'll finish this tomorrow, and then address any questions you have concerning exam 1, okay? Right now, I'm planning on no lecture, no podcast, or anything after the exam on Tuesday. So all you have to do is take the test and go on your merry way. So again, I have some additional information here. The Cleveland Clinic link worked, and then it wasn't working, so I just updated it today. It's back to working again. I love the Cleveland Clinic. They have phenomenal information there. And again, it's very kind of simple, puts things very simply there. But I will say there's a lot of stuff on those documents that I will not talk about. It's kind of an FYI. It's nice to know, more so than need to know. But it just presents it in a different way. So gestational diabetes, these are the folks who are at risk of developing gestational diabetes. None of these things should be a surprise to you at this point, because many of these things are at risk of developing diabetes. We often see diabetes develop at what age? Not childhood. That's the least common. The most common is usually in your 40s, right? So the vast majority of people with diabetes have type 2 diabetes, and it tends to be above age 40. That's like the predominant amount. So these are women who develop diabetes in pregnancy, and again, they're overweight, they're inactive, they have a family history, they belong to certain ethnicities where we see a higher percentage of diabetics, they've had gestational diabetes before, and if you have gestational diabetes, you're more at risk for developing type 2 later in life. So some things that may be less familiar to you, polycystic ovarian syndrome, PCOS. Believe it or not, there's a medication that we use for that called metformin. You know metformin as a medication for diabetes. It actually helps control blood sugar. It also helps stimulate ovulation. And so a lot of patients will use that to help minimize the amount of cysts that are on the ovaries, but also to see if that will help them with fertility, believe it or not. So that when you have a patient who's taking metformin, it's important to know why she's taking that particular medication. Hemoglobin A1C, feel pretty good about that? Hopefully that was hammered pretty hard for you. It's a percentage, and I'm always kind of wrestling with what percentage to use. I used to use 5 to 7%, which may still be in the slide here. It seems to be getting tighter and tighter, like 6 to 7%, 6.5 to 7, something like that. Some of it depends on your endocrinologist, but if you have an elevated hemoglobin A1C, it means you had too much hyperglycemia over a longitudinal picture. So over the past few weeks, you had high blood sugars. If you have a very low hemoglobin A1C, you have too much hypoglycemia. So in other words, if your hemoglobin A1C was 5, you have too much insulin. So we need to back down your insulin. If your hemoglobin A1C is elevated, you need more insulin. Everybody with me on that? Okay. If you have impaired glucose tolerance, and that's part of the reason we do the glucose tolerance test, resistance to your own insulin, and then history of cardiovascular disease. Now remember, some of this is physiologic, meaning that it's expected because the placenta is going to produce HPL, which antagonizes insulin, and that tends to come into play later in pregnancy. So it's after 20 weeks, but that's why we screen every woman at 28 weeks for gestational diabetes. So why is diabetes so bad? The big thing that we see with diabetics is they have a lot of pregnancy loss. So if you have a patient who's a gravida 4 para 0, it may be that she had undiagnosed diabetes. No one thought to check her blood sugar. The other thing that can happen is genetic defects. So babies that are born to moms with uncontrolled diabetes, they have heart defects, they have problems growing, their organs don't form correctly, so they have genetic malformations. And so sometimes they'll lose the baby that way in terms of a death in utero. So they're at high risk of stillborn as well. With mom, the big thing, if I had to look at that big list, and the thing that I would want to have in my head is preeclampsia. So if you're diabetic, you're at high risk for preeclampsia. So the pre part in eclampsia is pre means before seizures. Once you seize, you are now eclamptic. Okay. The old term for that is toxemia. We don't use that term anymore. But just like in real, in med-surg land, diabetes and hypertension are best friends. In pregnancy, they are still best friends. But other things that can happen, hydramnios. Hydramnios is the same thing as polyhydramnios. I know it's silly, but too much fluid around the baby. Ketoacidosis, so DKA. So you have a patient who goes into a coma. Labor dystocia is the fancy $10 phrase for a difficult labor. And what happens is that the baby can get so big, it gets in a malposition. Maybe the mom or the baby won't fit through mom's pelvis. So she might have to push longer, labor lasts longer, labor needs more intervention, she needs forceps or vacuum delivery, which poses more risk to her and the baby. And then retinopathy, you remember from med-surg that diabetes damages the eyes and the kidney, you have that microvessel damage. So I mentioned the fetal risks. When you have uncontrolled diabetes, you often have a big baby, and this is very important, hence why it's in red. So what happens is I've given you this sugary Kool-Aid, circulation, super syrupy, sweet, sugary blood for months and months and months and months. And then right at the time when you need it the most, we cut it off. And so the baby's blood sugar plummets after delivery because that's a stressful time. And I've cut it off for mom because I cut the umbilical cord. So we see hypoglycemia in the newborn. So blood sugar in babies doesn't have the same range that we have in the adult. So with babies, with brand new babies, we want that blood sugar to be above 40 to 45. I would be a little nervous if my adult patient had a blood sugar of 50, but I'm pretty happy if my newborn has a blood sugar of 50. Okay? So again, we watch the baby really carefully after delivery for hypoglycemia. If the baby has vascular, so in other words, there's vasoconstriction occurring concurrently, there's IUGR. So there are two things that oppose each other in this list. On one hand, I said you could have a big baby. On the other hand, I said you could have a small baby. I know, it's so confusing. That's nursing for you. How would I know the difference? How would I know if I'm having too big of a baby or too small of a baby? Right? Fundal height? Weight, possibly. Ultrasound would probably be another really good way, and again, that would be ordered by the physician. So somebody who has gestational diabetes, they're watching for too big of a baby or too small of a baby. And then hyperbilirubinemia, that's the $10 phrase for jaundice in the baby afterwards, after delivery. So you do a risk assessment on your patient when they first come in. So looking again at family history. A lot of women are telling us things like they have episodes of hypoglycemia. So they'll say, oh yeah, when I was young, I passed out, and my blood sugar was really low because I hadn't eaten or anything like that. So that I would make note of. It doesn't necessarily mean the patient has diabetes, but it may mean that they have some difficulty in regulating their blood sugar. Often in first trimester, if you have a patient that's having a lot of nausea and vomiting and she doesn't have much intake, she may truly be having hypoglycemia. So having episodes of hypoglycemia is not equivalent to having diabetes. People who are diabetic can certainly have hypoglycemia, but people who are not diabetic can also have hypoglycemia depending on what's going on with them. The classic symptoms, so you know the polys, polyphagia, polydipsia, polyuria. So you eat all the time, you're thirsty all the time, and you drink, and you pee all the time. So you eat and drink all the time, and you pee all the time. And in your urine, you are spilling glucose, more than a trace. The other thing, particularly in first trimester, that we notice is these are women who have recurrent urinary tract infections and yeast infections that are resistant to treatment by medication. And it's because that extra sugar is just food for pathogens to replicate and kind of set up shop. We look for, again, changes in the fundal height. We can do the screening earlier if we see significant symptoms. So let's say I've got a patient who weighs 250 pounds on her first initial prenatal visit. She had a history of gestational diabetes with her first baby. They may not wait till 28 weeks to do her glucose tolerance test. They might go ahead and do it earlier. The other thing is, we do not do glucose tolerance tests on type 1 diabetics. There is no reason to do that because the pancreas is not going to respond to the challenge of giving a bunch of glucose. You're going to make your patient very sick if you do that. So if she's a type 1 diabetic, we don't do the glucose test. We do urine screening at every visit, and then with the glucose screening test, we basically are dumping a bunch of glucose really quickly. And we want to see how the pancreas responds to the challenge. Remember that it's normally a challenging time anyway. Pregnancy puts strain on your pancreas, but we really want to say, "Chow, here's a bunch of glucose really fast," and then we want to see how you respond. And we usually want that 1 hour glucose tolerance test below 140. Now what I will tell you is some of our facilities here in town, we have OB providers. The 1 hour glucose tolerance test might be 132, and they'll say the patient has gestational diabetes, okay? So yes, there is a discrepancy there, but I think it's kind of better safe than sorry. I think part of it is to have the documentation there to support why you are seeing the patient more frequently, why you are doing biophysical profile testing and non-stress tests on the patient, okay? And I think it's this idea of there's risk there because just at that one time, maybe you didn't quite meet criteria, but it's not like, ooh, I passed my glucose tolerance test, I don't have to worry about it ever again. The risk continues as you progress in the pregnancy. All right, so do not memorize the values of the 3 hour glucose tolerance test, okay? Because you would always, as a nurse, look at the lab report and it would tell you. What I would know about the 3 hour glucose tolerance test is that's what we use to diagnose gestational diabetes. And we usually need 2 of the 4 values to be abnormal. Okay? So you may have one that's outside parameters, but usually it's 2. And with that, you have a fasting, so you have to educate the patient, nothing to eat or drink. They draw your blood the first time. Then you drink more glucola, which is kind of this super syrupy drink. And then they draw your blood at 1 hour, 2 hours, and 3 hours. So it's a 4-hour test usually. Okay. All right, HIV, you'll notice that with HIV, there's one slide. And the reason why is the care of the HIV positive patient is really not drastically different. The key thing when she's pregnant that we're concerned about, quite honestly, is infection. So she's at higher risk for infection, so she would want to take measures to prevent being around people who have illness. In terms of the HIV posing risk on the pregnancy, if she's being maintained with her antiretrovirals, we will adjust the dosages and make sure the medications that she's on she can take in pregnancy. We watch her viral count pretty carefully in pregnancy. And again, we try to keep that pretty low. And if we're able to do that, we try to have delivery in a very planned fashion. But if the viral load is very low and the CD4 count is high, we can usually do a vaginal delivery. And lately, the few patients that we've had in clinicals who've been HIV positive, they've been managed very well. And so they had a successful vaginal delivery and everybody did fine. Baby was fine, mom was fine. They did have mom induced because they wanted her to be controlled in terms of delivery. They didn't want to have kind of hemorrhage and different kind of unplanned things that can happen. The other thing is we used to do C-sections on moms that were HIV positive, and we actually found that that actually increased the risk of transmission. So that's one of the reasons you're seeing a change in practice. So if your patient is HIV positive and she says, I've heard I have to get a C-section, that is not necessarily true. There may be other reasons to do a C-section, but it's not because of her HIV status. Does that make sense? Okay. In the United States, we do not recommend breastfeeding, and it's because in the United States we have an alternative to breast milk. In other parts of the world, moms don't have any other nutrition available to give their babies, so they're going to breastfeed their babies. So they would there's the risk of transmitting the virus to the baby in breast milk. But in the United States, we would have mom's formula feed. Okay, I do not want to start heart disease.